other effects, which more often than not are their toxic effects. So when we talk about the opioid analgesics, they are drugs that include naturally occurring, semi-synthetic, and even totally synthetic drugs. And we'll be able to look at each of those examples. They have a morphine-like action. I had asked you yesterday to draw the structure of morphine. I hope you have, because we'll be able to move faster and you will understand better. So we say they have a morphine-like action, namely, they bring relief from pain, so they will suppress pain. At the same time, they will also bring depression of the CNS. In other words, when they bring depression of the CNS, it means they will bring sedation. So these are the characteristics. And depression, they will also bring about depression of the CNS associated with drug dependence, with exception of one or two after structural modification. Most of these drugs, which are opioid analogs or opioid drugs, have a problem of drug dependence. And when you get the drug dependence, we're also talking about drug addiction, dependence, and tolerance. And that is why you find even many celebrities, many people die from these drugs, especially when they bring tolerance. To have those effects, these drugs also have things like euphoric. They have the euphoric effect. You want to have that euphoria. You want to feel above the world, extremely happy for no reason. Then when you get tolerance, because you want to feel the same effects you are feeling with lower doses, you continue to increase the dosage. And as you continue to increase the dosage to have the same effects you are having with lower doses, you get to a point and you cross over. Because as we have seen, these drugs cause CNS depression. They cause respiratory depression. So they will kill you as you look for those, for the good feeling. Opioid drugs are also used for other purposes, including induction of sleep. In other words, they can cause sedation, especially in the presence of pain. They can also cause as anti. In fact, they can cause, including opioid drugs are also used for other purposes, including induction of sleep in the presence of pain. Actually, they can also, like Lomotil, they can bring about constipation. So they can be used for diarrhea. They can also be used as cough suppressants. When we are preparing you also to go out there, and some of you, of course, all of you visit the retail market. Kindly find out. I think they were banned, but you have unscrupulous people out there. But you would find that codeine is found in quite a number of cough suppressants. We used to have, in fact, there is one which was used to be very, very, very famous. I've forgotten the name, but you find that codeine is a cough suppressant, and it used to be mixed with quite a number of cough suppressants. But there was a new rule. And there was a new pharmaceutical rule which banned some of these drugs from OTC medicine. Then they can also cause suppression and anesthesia, cough suppression and anesthesia facilitation. Some of these drugs we will also find out that we also use them in the theater when we are doing surgery, a drug like fentanyl. So you can see they have a wide range, starting from analgesic pain all the way to the CNS depression to bring about sleep, and even in theater can also be used in patients who have diarrhea, can be used for cough suppression. But the major danger is the fact that since they're acting in the brain, they can bring about, as I have said, they can bring about addiction, they can bring about dependence. And when you talk about dependence, this person cannot do any work without having this drug. The body cannot survive. And when you get their dependence, of the physical dependence, it means when the level of these drugs decreases in your body, you have withdrawal symptoms, you start sweating, you start shaking. And that is why you find these people hooked completely, because the minute you withdraw these drugs, there is a withdrawal symptoms, and the withdrawal symptoms are so severe that the person opts to go back so that they can take care, or they can minimize the withdrawal symptoms. So that is something that we need to always keep in our minds that the narcotic analgesics, as potent as they are, they have that action, dependence, and tolerance. An analgesic drug is a drug that reduces or eliminates pain. So when you talk about analgesia, you are reducing the pain. Narcotic or opioid agents are potent analgesics which are effective for the relief of very severe pain. And indeed, even for quite a number of people, when you get diseases like cancer, and a time comes and all they are doing is giving you palliative care. Palliative care, they can see there's nothing they can do. The disease has really progressed. They are giving palliative care. Some of the drugs they give you is a drug like morphine to kill the pain because it's a very potent. But you hear have said already, when they start you on it, you get hooked. So you will, of course, but either way, when of course you have that cancer, it's devastating in its own way. So the narcotic opioid analgesic and in the spinal cord, which are used, and they, of course, they are used for very severe pain. The analgesic effect of opioids are due to decreased perception of pain, decreased reaction to pain, as well as increased pain tolerance. So those are the three things they do. They decrease the perception of pain, they decrease the reaction to pain, and also they increase the pain tolerance. These drugs are commonly prescribed to manage pain, but can also be prescribed to treat, as we have said, diarrhea or severe cough. Natural opioids are derived from opium, which is a partially dried latex harvested from the opium poppy, which we call Papaver somniferum. So we are saying we do have the natural opioids. They occur naturally, but once they occur naturally, we can of course be able to do structural modification to get other molecules that have the same effect of analgesic, analgesia, and perhaps lesser addiction, lesser tolerance. The same way we have been doing that. Normally you start with a natural product, you look at its activity and you see whether you can improve. Either you can improve on its profile, be it its pharmacological activity or even the side effects. So they are harvested from opium, poppy, or Papaver somniferum. Opium contains morphine, papaverine, and the bane. So all this are obtained from opium. The bane is a convalescent drug that produces no analgesia and as such is not used clinically. The bane is an important synthetic intermediate in the production of the semi-synthetic opioids. Because of its natural source, morphine and morphine derivatives are referred to as opiates. So we call them opioid analgesics because they are harvested from opium. That is where the name came from. Because of the fact that they are harvested from opium poppy, then we call them opioids or we call them opiates. What kind of receptors do these opioid analgesics bind, or the opioids? The opioid receptors belong to the family. I believe you have heard of G protein coupled receptors. And there are quite a number of these receptors. We will mainly emphasize on three, which are most important for the analgesic pain. Morphine, or for the analgesic activity. Morphine and other opioids exert their action by interacting with specific receptors present on the neurons in the central nervous system and also in the peripheral tissue. So they can work centrally, but they can also have a slight activity in the periphery. And we have mainly, especially in the periphery, is mainly in the GIT. We have talked of them being used for diarrhea. For them to be used in the diarrhea, they must bind the peripheral receptors within the GIT, and that is how they act peripherally. But otherwise, the other action is usually central. So we have main three types of receptor. We have the mu receptors, we have the kappa receptors, and we have the delta receptors. They are not about to, but they are really not involved in pain management. So when types of opioid receptors, so we are talking about the mu, the kappa, and the delta. And let us look at the mu receptors are responsible for supraspinal and spinal analgesia. So they're used for supraspinal and spinal analgesia. They cause respiratory depression. And indeed, this is the killer for most of the people who die of morphine toxicity, of almost most opioid toxicity. The killer is this respiratory depression, because as you increase the dosage, you depress the respiratory system. Once you will get to a point and it is completely depressed, so it will not work. It will just completely fail. Of course, once your respiratory system fails, of course, you are gone. So respiratory depression and also gastric motility reduction, and we have said that is why they are used as antidiarrheal agents, because they do bring constipation. Another effect, as we have said, is the euphoria. This is also what people go for. Those people who abuse these drugs, especially, and you have seen many celebrities, very many celebrities, especially the musicians, dying of these drugs. What they are looking for is a euphoria. They want to be high. They want to be very high, especially when they are performing, so that they can be able to do anything and be able to excite, of course, the audience. Physical dependence and meiosis. So they can also cause, we've already mentioned, physical dependence and meiosis. So meiosis, of course, is constriction. So once these drugs bind the mu receptors, you can get all those effects. They can also bind the kappa receptor. So one drug like morphine will bind, it has ability to bind the mu receptor. It has also ability to bind the kappa receptor, and also has ability to bind the delta receptor. The difference is that it will bind those different receptors at different rates. So you find a drug like morphine has much more ability or affinity for the mu receptors than the others. So that usually is the difference, but they are able to bind the different receptors. So you have the kappa receptor, and this one, here again, respiratory depression. It also causes dysphoria. Dysphoria is a depressed, low energy state, and this is usually a major problem for these also people who abuse these drugs. And after you are so excited in the night, you've done everything. In the morning, you wake up to a kind of depression. You are kind of depressed in the morning. And that is why, again, these drugs will continue driving you, because you cannot withstand that state. And you want to go and get another dose. Euphoria. Then there is the hallucinations. Again, terrible effects. Of course, we're going to do the CNS hallucinogens, and then you have meiosis. So when we are looking at the hallucinogens, we will discuss the hallucinations in details. So I don't want to go into that now. Then there is meiosis, as we've already said, sedation, and also nicotinic effects. Then you have the delta receptors. And the delta receptor activation produces, again, spinal analgesia, respiratory depression, effective behavior, reinforcing action, and reduced GIT motility. The effective behavior reinforcement action is like what you see when you're training dogs, that when you give them something, then you give a gift. So those kind of things that can also be triggered by these drugs. So these are the various receptors that we have for the opioid analgesics, and all those receptors can be bound by the various drugs that we're going to discuss to different extents. Different drugs have different intrinsic activity towards the different receptors and different affinities towards the different receptors, and that also is actually what brings about their differences in their potency, their differences in their efficacy, because of the intrinsic the intrinsic and the affinity they have for the different receptors. We now go to the classification of the narcotic analgesics, and we can classify them in different ways. We look at about 2 or 3. We can classify them based on receptor interaction and source. Receptor interaction. We talk about receptor interaction. What we are talking about is this drug an agonist? Is it a passive agonist? Is it an antagonist? That is what we're talking about, receptor interaction. And then the source. Is it naturally occurring? Is it semi-synthetic? Is it totally synthetic? So we are classifying them on the base receptor interaction and their source, and we are putting that together. So we are talking about the first category is the pure agonists. So these ones are purely agonists. And we have, of course, the naturally occurring, where you have the opium alkaloids, or alkaloids, or what we have called the opiates. And in that one, we have morphine and codeine. Of course, as we are going to see, codeine, and we'll be able to see how does that structural modification of morphine to codeine influence the activity of the resultant drug. Then the semi-synthetic analogs. Semi-synthetic analogs is where we are starting with morphine. So you start with morphine and you look at the structure of morphine, you look at the peripheral substituents, and you see, however, you can structurally modify any of those peripheral substituents to get another drug. And of course, then you measure, you check on the activity, on analgesic activity of the new drug. So in semi-synthetic analogs, we have the hydromorphone. As I said, I don't know whether you have drawn these structures. We will look at hydromorphone. Please note the word hydromorphone, because the bond at position 7 and 8 is saturated. We have the oxymorphone. If you look at oxy, it means it has an added hydroxyl group or an added oxygen. The oxymorphone has an added hydroxyl group at position number 14, and therefore the oxy. And of course, we have the oxycodone. When you look at these, if you look at the first one was fine. This is phone, and or we can say the own, better own. So when you look at I and E and you see own, this own is telling us that there is also some group in the morphine that has been oxidized to give us a carbonyl group or a ketone. And if you have drawn the structure of morphine, I hope you have noted there is a 6-hydroxyl group in morphine. And when you see an own, of course, there are more examples of semi-synthetic analogs. When you see the own, it means the hydroxyl group in morphine has been oxidized to the ketone. Again, we look at all those compounds and we'll be able to see what is the difference. When you see in codeine and you see own, it means again, there is a group, and it's the same group. The 6-hydroxyl group has been oxidized into an oxo group or into a ketone. Then you have the synthetic compounds. So these ones are not semi-synthetic, they are completely synthesized in the lab. And you have meperidine, and meperidine also pethidine. And we will again look at all these compounds. We will state which class they belong to, because they belong to different classes. You have meperidine, you have levofanol, you have methadone. This, when you visit, for those of you who will be lucky to visit a Mathari hospital, they use a lot of methadone, because methadone is used as a detoxifier for those who are abusing morphine and derivatives. So fentanyl, fentanyl, these are the ones now have general anesthetic activity, especially fentanyl. When you go again for your hospital rotation, kindly also ask or check on the drugs that are used in theater. Fentanyl, very, very common. Remifentanil also a drug that is in the same class as the fentanyl, also for theater. And also levomethadone. Levomethadone is a structural derivative of methadone. Methadone, again, it is used in rehab centers to try and control, or to try and give detoxification to those who are on the opioid. So that is the first category. We have done quite, I think, 2. So we have looked at the pure agonist, and where we have said under the pure agonist, you can have those which are natural, you can have those which are semi-synthetic, you can have those which are synthetic. And we have given good examples for that. I hope that is clear. Then from the pure agonist, we move to the mixed agonist antagonist drugs. When you talk about the mixed agonist antagonist drugs, it means they can bind one receptor and bring about agonist activity, bind the other and bring antagonist activity. Especially most of them will bind the mu receptor with agonist activity, but when they bind the kappa, they bring antagonist activity. So they have the mixed agonist antagonist effect. And of course, again, here we do not have the naturally occurring. We start with the semi-synthetic, Again, when you talk about semi-synthetic, these are derivatives of morphine. These are derivatives of morphine, and you have nalbuphine and you have naloxone. A short while, but I hope you so you see this view. It means there's a four-membered structure somewhere. So nalbuphine and naloxone, those are mixed agonist antagonist drugs, and then you have the synthetic, which again are mixed agonist antagonist, and you have pentazosine. Again, we will look at all of them. Just note the drugs. We will be able to look at all of them because indeed some of them, most of them belong to different classes. And when we talk about mixed agonist antagonist, we are saying they have agonist activity at some receptor and antagonist activity at another receptor. So those are the ones we call mixed agonist antagonist drugs. So then the other category, we are still classifying according to the receptor interaction. We do have what we call the partial agonists. I think I need you now. I hope perhaps you have already read. What is a partial agonist? Because I know you have heard of a partial agonist. What's a partial agonist? Quickly, we don't want to waste time. We want to go fast. What is a partial agonist? I believe you have. I think we used to do that in, was it pharmacology in the at the beginning, introduction. Have you mentioned about types of ligands which bind the receptors? Well, can I have some message public chat? Can I have something there? What is a partial agonist? What's a partial agonist? If you haven't, if you do have never heard, just say you haven't. Have you ever heard of something like a partial agonist? Yes, Edwin? Partial agonist? I hope you have not gone Google. That's a problem. That's why sometimes I don't ask questions. Because when I ask and you're on the other side, some of you just go Google within a minute. But it doesn't help. Within a minute, you already Googled. But yeah, those are the disadvantage sometimes of technology. There's nothing we can do. Quickly, something so that we move on. We don't want to stay on this for too long. It produces an agonist effect when it binds to a receptor, but less than what is produced by a full agonist. That is correct. Binds to receptor and produces partial response. Binds to a receptor and produces partial response. Yeah, I think you have the. But you see now, I'm asking you partial, and then I thought you were taught when you are explaining something, you don't use the same words which are in the question. You have been asked partial agonist in your description. You cannot say it. it will stay for a very short time.
I want to see the
But you can't go for. Sorry, I lost power. I hope you can hear me. I lost power, but I've connected to my phone. I don't know how. We lost power. I don't know. So we were looking at. Can you hear me? I hope you can. I'm using. You can hear me, please. Can you hear me?
Yeah.
Oh,
yes, we can hear you.
Yes, I lost my connection. So we were looking at the patio, but now it can't move. Now, how do I move the slides? Gosh. What has happened? Slides can't move. Oh, I haven't come. So we were. Wait. Lights are back, so let me connect again. There's no competitor. These KPLC people can really mess us. So we were looking at a passive agonist, and I was just explaining that if you asked a question, don't use any word or any terminology that has been used in the question to answer, to do the answering. Like I've seen some of you are saying it has passive activity, which is correct, but then you have not defined what passive means. So that can cause to get you full marks. So we were looking. Sorry. So we were looking at mixed agonists. That one we had done. Passive agonist. These are semi-synthetic, and we have again two examples. We have butorphanol, we have buprenorphine. Just note them as we move on. You will be able to know each of the structure, even of each of those drugs. And of course, we are saying the passive agonists are those drugs that will not excite or will not bring about full efficacy. They will not bring about full efficacy, or they will not bring the same expected activity as that of the full agonist. So you have butorphanol, you have buprenorphine, and then you have the narcotic antagonists. And of course, when you talk about narcotic antagonists, or not only narcotic, whenever you talk about any drug which is an antagonist, remember an antagonist sits on the receptor, but it has no intrinsic activity. So it does not activate the receptor. So that is how it becomes an antagonist. It sits on the receptor, it blocks that receptor, the receptor cannot be accessed by the agonist, and when it sits, when it sits there, it does not have any intrinsic activity. It cannot activate that receptor. It's like what you call a dog in a manger, whereby it's sitting in a manger. It will not eat what is there, but it is blocking any other animal to feed on whatever is in the meat. So that is the same thing. So when you look at the semi-synthetic, we do not have any naturally occurring antagonists. We have only semi-synthetic. We have naloxone. Now, trexone is an example. We also have Nalfine and so on. But we are saying these are drugs that have no intrinsic activity, but they've got very high affinity for the receptor, and therefore they will bind the receptor very strongly. So do not have agonist activity at any of the opioid receptor sites, block the opioid receptor, inhibit pharmacological activity of the agonists, and precipitate withdrawal independent patients. And we had mentioned two drugs, nalbuphine and nalorphine, which we said were mixed agonist, antagonist, and I did mention that they will have structural resemblance to morphine. And if you look at your morphine structure, it has a hydroxyl group there. It has a hydroxyl group there, of course, then alpha orientation. The morphine has up to here a methyl group. But when you look at a drug like nalbuphine, you find the B before it has a cyclobutyl ring connected to a methyl group, and that gives it mixed agonist antagonist activity. Then we have I also talked about nalorphine. Again, if you look at nalorphine again and morphine are actually very close. Hydroxyl group there, everything the same. But of course, I forgot for nalbuphine. Please note it has a hydroxyl group at position 14. We'll talk about the influence of that group. But when we look at nalbuphine, as you can see, fine, it is again nalorphine, again an analog of morphine. You find that it is at position number 17. We're going to mention the numbering where you have an allele group. So it has an allele group at that position, CH2, CH, double bond CH2, and we will discover that when you add that group at position number 17, you introduce antagonist activity. But because of the fact that it retains the same structure as morphine, it can still have some attraction, or can still have some intrinsic activity at the agonist receptors, and therefore have mixed agonist antagonist activity. I drew these structures because I don't think I will draw them later. So you have the nalbuphine, and from the name, as I have said, you have that cyclobutyl ring, and then of course at position number 14 it has a hydroxyl group, and we have of course the nalorphine, which only has an allele, and you can use that L to remind you it's an allele group. Everybody has to have their own way of remembering this most of the structures. So that is the classification based on the receptor interaction and the source. And we are talking about, is it an agonist? Is it an antagonist? Is it naturally occurring? Is it semi-synthetic? Is it synthetic? Again, we can also now we are going back here, you're going back to the opioids based on the chemical structure. The opium alkaloids, this is just the opium. These are the ones which are naturally occurring. So we've already mentioned the naturally occurring as the first category, naturally occurring opium alkaloids. So we want now to further classify these drugs because they can be further subdivided. They are all opium alkaloids, but they can further be subdivided into two classes now, depending on their structure. So that's what we are doing. Based on the chemical structure, opium alkaloids are further classified into two types. You have what we call the phenanthrene derivatives. And we talk about phenanthrene. This is the phenanthrene, where you have those three rings. That's the phenanthrene structure, and where we have morphine, we have codeine, and we have thebaine. So those three, morphine, codeine, and thebaine, are phenanthrene derivatives, and they are, of course, they are opium alkaloids. Then you can also have the benzoisoquinoline derivatives. And this is the benzo, and this is what we are calling the benzo. This is what we are calling a benzyl group. Whenever you have a phenyl group attached to a methyl group, it becomes a benzyl. And that's why we are calling them the benzo isoquinolone. So this is the isoquinolone, and we are calling it isoquinolone because the quinoline will have this nitrogen at this position there. So if it was a true, if it was a quinoline, then the nitrogen will not be at position 2, it will be at position 1. So when the nitrogen is at position 2 of the naphthyl, so of course you have the naphthyl ring, and when the nitrogen is at position 2 rather than position 1, you call it iso. When it is at position, of course, 1, it is a quinoline. So that is the difference. And they are benzo because at position, and that we don't have a nitrogen there. At position 1, you have the benzyl derivative. So they become benzyl. You can call them either benzyl isoquinolines or in fact, we should put here is benzyl isoquinolines. It is much better. So benzyl isoquinolines, whereby they have a benzyl group at position 1, and the nitrogen has been pushed to position number 2. So under the benzyl isoquinolines, we have the papaverine, we have the noscapine, we have the narcine. We will not study any of them because they do not really have any analgesic activity. Remember, the topic is narcotic analgesics. So we are really going for those drugs that have analgesic activity. So we mainly stick to morphine, to codeine. We say the bane also does not have that activity. And I drew the structures of the bane. So you can see the difference between the bane and morphine is that both of the hydroxyl group have been methylated. So it is a derivative of codeine, more closely, a derivative of codeine. Codeine has a methoxy group there. So it has a methoxy group at position number 3, and it has a methoxy group at position number 6. Everything else resembles the structure of morphine. Everything else resembles the structure of morphine. You can see the papaverine, which we have said, the benzyl isoquinoline, and you can see again the same. So papaverine, that is here, isoquinoline, and then of course the substituted benzyl group. It has a lot of methoxy groups, but as I have said, it's because I've mentioned them in the notes. That's why I thought it's important for you to know the structures so that you can associate the name with something. So then you're still on the classification. So that classification just done was only of the opiates, all the naturally occurring opiates. But of course, we do have also the semi-synthetic and the synthetic. So that's why we are continuing to classification of narcotic analgesics according to source. So you have the naturally occurring and semi-synthetic, where you have morphine and analogs. So these are naturally morphine, codeine. Analogs are semi-synthetic because you have structurally modified one of the groups. That is why we are talking about the naloxone, butyrfine. We are talking about naloxone. All of them. No, naloxone, sorry, it's an antagonist. We are talking about codeine. Codeine is naturally occurring. We are talking about all the hydromorphones, the oxymorphones. All of them are semi-synthetic because they do not occur naturally. You must start with the morphine. You do structural modification to get those compounds, either for improvement. Some of the structural modifications increase the analgesic activities, others decrease the analgesic activity. So that's class A, naturally occurring and the semi-synthetic. Again, we're going to look at them in details. Then we have the group B. And the group B now are all the synthetic compounds. I've mentioned a number of them, but haphazardly. Those synthetic compounds can also be divided into specific classes depending on their structure. And of course, we have the morphinan derivatives. We will look at them, and we will understand what is morphinan derivatives, how are the morphinan derivatives related to morphine. And under the morphinan derivatives, we have levofano, butorphanol. Then we have the benzomorphan. Kindly note the difference between this. This is morphinan, this is morphan. So that when you are writing your name, make sure the name is correct. There is a morphinan and the morphan. Again, you will see how do they relate with morphine. And we have the pentazosine, we have the phenazosine, cyclazazine, and so on. And then we have the phenylpiperidine derivatives. You can see from the name, we are talking about there is a phenyl ring and there is a piperidine ring. If you look at morphine, you'll be able to see a phenyl ring and a piperidine ring. That means we have gotten rid of all the other rings, and now we have only a phenyl and a piperidine modifications, because the phenyl ring and the piperidine ring join together on their own. They will not bring any analgesic activity. So you do the necessary structural modification to the phenyl ring, join to the piperidine, plus the other substitutions, and you get compounds that have activity. In this category, under the phenylpiperidines, we have two groups again of drugs. Like you have meperidine, which I said is the same as pethidine, which is usually used for pain, even in labor ward, whereby the mother is having a lot of pain, or the mother-to-be is having a lot of pain. So you can give them pethidine or you can give them meperidine, and of course also fentanyl. And when we come to look at fentanyl, we will see, yes, it's a phenylpiperidine, but it belongs to a subclass of the phenylpiperidines, which we call anilidopiperidines. But as we move on, you will be very clear in your mind of all these different drugs. And then finally, we have the phenylpropanoamines. I hope from the name, you note something. There is a phenyl group, just as in the other one. Then now you have a propanoamine. So we do not have piperidine. So the piperidine ring has been broken, has been opened up. The piperidine ring has been opened up, and you have a phenyl group, the propanoamine, again with appropriate substitution. So the substitution must be appropriate, and in that class, that is where you get the methadone. The methadone, the propoxyphene. This propoxyphene, again, when you go out for your rotation, again, look at some of the over-the-counter drugs. You will find that they have propoxyphene, and it will not just be propoxyphene, it will be dextropropoxyphene. And as we, of course, we will have studied about it, dextropropoxyphene has some antitussive activity, has some analgesic activity. So again, those are now the synthetic drugs, the synthetic narcotic analgesics, and we will find out that all these synthetic drugs have been obtained from morphine by structural modification. So from the start, we are saying we do not require that very complicated structure of morphine, which has 5 rings. We don't require the 5 rings for activity. We require a very small skeleton, which we are calling the pharmacophore. We require a very small portion of morphine. But when we are talking about morphine, all those structures, all those rings, all those peripheral substituents must be there for that drug to be morphine and for that drug to give us the analgesic activity. So that is the classification. Now, I hope you have your structures. I want us to look at some of the structures. Let me close my door. Just hoping that you've drawn some of the structures, because when you draw them, you start getting used, and you must draw these structures very, very quickly. You must learn to draw them very, very quickly. So you must practice a lot. So we have morphine, and that is a structure of morphine. It's a naturally occurring opiate. It's a naturally occurring narcotic analgesic, and you can see what we are saying. We are going to discuss that. That's ring 1, that is ring 2, that is ring 3, and then here there is ring 4. This ring here, which goes like that way, that way. That is ring 4, which you can see is a piperidine ring. So that's ring 3. We have the ring 5 there, which you can see it's a dihydrofuran ring. So morphine, as you can see it from that structure, has 5, 1, 2, 3, 4, 5. So it's pentacyclic. And added to that, it also has some peripheral substituents. We number it, that's position 1, 2, 3, 4, and so on. We're going to look at that. So this is, we say that is position 3. We have a hydroxyl group. This is position 6. it has a hydroxyl group. This is position 7-8. It must have a double bond. And then at position number 17, it has a nitrogen which is substituted with a methyl group. That is a structure of morphine. So when you are discussing morphine, it must have all those structural features for it to be called morphine and for it to have the analgesic activity. Then from there we go to codeine. If you look at codeine class, just note the hydroxyl group has been changed to a methoxy group. And that's the only difference. Everything else remains the same. I hope if you have drawn these structures, you'll be able to follow very easily. Then we go to heroin. Is a derivative of morphine where there is acetylation. That's an acetyl group. Acetyl group tumeisoma sana. That's that acetyl group. So both hydroxyl groups at position 3 and 6 have been acetylated. That gives you heroin. And I hope you know the difference between heroin and morphine. Heroin is a very potent narcotic analgesics, and it has, of course, everything else. When it's very potent, all the side effects are also more positive. So it will be more euphoric. So, of course, it is. Then I want us, first of all, to leave that because that one has something different. We were looking at the derivatives of morphine. Then you can see we are having the hydromorphone. I had told you when you see on, you must remember there must be some change somewhere. And if you look at the hydroxyl group at position number 6 here, it has been changed into an oxo group. The double bond has been removed. And that is why the hydro, because there is saturation, hydromorphone, not hydromorphine, but hydromorphone, because the hydroxyl group at position number 6 has been oxidized into a ketone or into an oxo group. And then also there is also even this one, there is reduction, because when you have a double bond, then that's an oxidation. But when you add hydrogen, it can also be considered to be a reduction. So the double bond has been oxidized, the unsaturation, the drug is now saturated, and then no wonder hydromorphone, because there's an addition of a hydrogen there, addition of an extra hydrogen there. Then we go to the hydrocodone, it is the same, only that that's a methoxy group. Everything else remains the same. Then you go to oxy. Whenever you get an oxy, as I had said, it is because of the hydroxyl group at position number 14. So that compound has everything that is found in the hydromorphone or in the hydrocodone, but now there's an added hydroxyl group. There is saturation of the double bond, there is oxidation at position number 6, but we have also addition of hydroxyl group at position 14. So if you see any compound which has an oxy, then you know first thing is that you put a 14 hydroxyl group before you forget, a 14 beta hydroxyl group before you forget, because that's what the oxy now stands for. The codone, as we have said, stands for saturation of the double bond between 7 and the 6 hydroxyl group to a ketone. I want first of all to look at so that is that. So we can look at the other now structures which are there. So those are some of the semi-synthetic. So first of all, I was looking at the semi-synthetic derivatives. Of course, I have looked at the naturally occurring first, natural occurring being morphine and codeine, and then the semi-synthetic, hydrocodone, oxycodone. Let us now just look at some one or two of the semi-synthetic, of the synthetic. I'm bringing them this early because we have mentioned them in the classification, so you have an understanding. So we have talked of morphinan. We have talked of the morphinan, and we gave an example of levofano. Give an example of levofano. Well, therefore, the morphinan, if you look at this, we are calling the morphinan. you can see one of the very, very obvious structural modification, and it is removal of ring E. So if you look at this ring is not there. So that is a very, very obvious change or difference between morphine and the morphinan. The morphinan do not have this ring and that portion. And when that ring is removed, I told you also must do appropriate structure that has the necessary activity. It is also connected with. So the removal of this ring is also connected, or in addition, there is also, you can see, saturation of the 7-8 double bond of morphine, and also complete removal of the hydroxyl group. So when we talk about, when we are looking at the classification, that's why when we say the morphinan derivatives, the morphinan derivatives will not have the double bond at position 7-8, and they will not have the hydroxyl group at position number 6. So that is the major difference between the morphinan and the morphine. And you can see an example here whereby R is always a hydroxyl group,